So good afternoon, everyone. I would like to introduce you to my topic, identifying critical points in the management of patients with liver diseases. My name is Petrana Martinekova, and currently I'm first-year PhD student, as well as medical tutor at EDU Degree Smarter Institution. I work on my projects with the great help of my supervisor, Kristina Hadimasi, and my SMS, Mahmoud Obeidat. My vision is to improve outcomes and care in patients with liver diseases with evidence-based and personalized approach. I would like to identify gaps and opportunities for improvement. My mission is to investigate the current evidence of nutrition, of efficacy of nutrition and fat-soluble vitamins, and the early prediction of bacterial infection in patients with liver cirrhosis. For my vision and my mission, I am currently working on two specific projects, both of them using the methodology of systematic review and meta-analysis. The first one that started September this year is the efficacy of vitamin D supplementation in patients with chronic liver disease. The second one that started November this year is the diagnostic accuracy of inflammatory markers in cirrhotic patients with bacterial infection. So let me start with the first one, the efficacy of vitamin D supplementation in chronic liver disease. To understand the importance of the topic, there are a few critical points worth mentioning. First of all, chronic liver disease led to almost 300,000 deaths in Europe in 2019. We do know that on average, 2/3 of mortality occurs in individuals below the age of 65 years, therefore a significant year of life being lost. Vitamin D deficiency is prevalent in this group of patients. It accounts for about 49 to 86%. And based on the result of the study published in 2019, severe vitamin D deficiency was associated with increased all-cause mortality risk in patients with liver cirrhosis. Also, meta-analysis on randomized controlled trials done in 2016 came to the conclusion that vitamin D administration might reduce mortality. Therefore, our aim is to evaluate the efficacy of vitamin D supplementation in patients with chronic liver disease. You may ask, why vitamin D and why liver disease? You can see the summary of the results on this picture. I just want to highlight that vitamin D has a pleomorphic effect, the skeletal ones being well recognized by scientists and clinicians, but also extraskeletal effects such as anti-inflammatory, immunomodulatory, or anti-fibrotic properties. So we ask the question, can vitamin D supplementation improve survival and outcomes in patients with chronic liver disease? To answer this, we use the PICO framework with intervention being standard of care plus vitamin D and comparison being standard of care plus placebo or no intervention. And we look for several outcomes, namely mortality, change in the liver enzyme, or fibrosis level. Our hypothesis is that vitamin D supplementation improves outcomes in patients with chronic liver disease, and we see the clinical implication of this in improving the care and, if possibly, prolonging survival. We did our systematic search November this year using these three main databases and this final search key. The first domain consists of vitamin D or synonyms. The second domain is in regarding to the liver disease. And the last domain is random because we are interested only in randomized controlled trials. You can see the flow chart over here. So at the beginning, we identify more than 9,000 articles. And after the duplicate removal and title and abstract selection with my co-investigator, Mihaela Topala, we came to the number of 76. Yesterday, we concluded our full text selection with approximately 44 eligible studies. Now I would move to my second project, diagnostic accuracy of inflammatory markers in cirrhotic patients with bacterial infection. As I said, patients with liver cirrhosis die prematurely. And we do know that bacterial infection accounts for 30 to 50% of deaths. Also, bacterial infection is the most common precipitant of acute and chronic liver failure. Infections in patients with liver cirrhosis increase the mortality 4 times when compared with the general population. Our patients are prone to any type of infection, spontaneous bacterial peritonitis and UTI being the most frequent one, while pneumonia carrying the highest risk of mortality. To do diagnosis of bacterial infection in our patients is complicated because, for example, clinical symptoms might be mild or even present in patients without real infection. And also some study pointed out that commonly used inflammatory markers such as CRP or procalcitonin have only moderate sensitivity and specificity. So our aim is evaluate the diagnostic accuracy of inflammatory markers in patients with liver cirrhosis and bacterial infections. And we ask the clinical question, what is the best inflammatory marker for early detection of bacterial infection in these patients? We use the framework PEERT with index tests being CRP, procalcitonin, presepsin, or interleukin-6, and with reference tests being microbiologically or clinically documented infection. And we see the importance of this because with the early detection of bacterial infection, we can reduce morbidity, mortality, but also we can help in stopping the spread of multi-drug resistant bacteria infection, which is becoming more prevalent in these patients. We did also our preliminary search key with preliminary search with the final number of hits about 8,000. We identify previously published meta-analysis on the topic. It was published September 2014, but it only compared C-reactive protein with procalcitonin. There is no Prospero registration currently, and with this preliminary search, we also identify our 5 key articles. So let me sum up. Those are my 2 projects, and the estimated submission date is summer the next year. I would like to conclude my presentation with the quote of Galileo Galilei, who originally said, "Non ho mai incontrato un uomo così ignorante, dal quale non abbia potuto imparare qualcosa," or "I have never met a man so ignorant that I couldn't learn something from him." Thank you for your attention.
Very nice presentation, congratulations. I have one question regarding your first topic. If you are taking into account several important confounders like geographical location of the patients, because the vitamin D deficiency is very much different in Nordic countries rather than Southern. And on second one, if you are taking into account the weight of the supplementation, if it is like tablets or sprays or etc.
Thank you for the question. So regarding the geographical location, so far what I know about our studies, and it's interesting, there are only few randomized controlled trials being done, for example, in Europe regarding this topic. The majority of the studies is coming from Asia, for example, from Pakistan or India. So this, we would take it into account, also this one. And the another thing regarding the administration, the way of administration of vitamin D, or even the dosage, it varies significantly between the studies. So we would like to do also the subgroup analysis regarding this topic, because it could be applied in the multiple ways and weekly or daily basis or monthly basis, depends how are you going to administer this vitamin. So yeah, we would like to take this into account. Thank you.
I would like to know if you are going to include as well serum levels of vitamin D, because one thing is you taking the vitamin D supplementation, other thing is you metabolizing it. For example, if you put a fatty food along with the supplementation, this will have another absorption level for this patient. So are you going to look at also the vitamin D levels after supplementation?
Mm-hmm. Yes, we would like to also check the vitamin D levels, and as I know, a lot of studies also included this, like if there was an increase in the vitamin D level in patients who got the supplementation, they compare with the other group. So this we would definitely take into account. And the good thing about vitamin D supplementation is that the compliance you can measure, for example, in the patients.
Very nice presentation. I have just a question regarding your second topic. For the reference test, you said that you would also include the clinically documented infection. And I wanted to ask why not just the microbiologically documented infection?
Mm-hmm. Thank you very much. So we based our decision because of the guidelines. For example, the bacterial culture, as far as we know, it has the sensitivity, for example, about 60% in patients who has real bacterial infection. And we know that for spontaneous bacterial peritonitis, for example, according to the EASL guideline, to diagnose it, it's important to have a polymorphonuclear count increase level in the ascitic fluid, but not, for example, the bacterial culture being positive both in the blood or in ascites. So that's why we have this. We have taken this into account, and we don't use only bacterial culture as the reference test. Thank you.
Congratulations on your presentation. My question is also regarding to the vitamin D supplementation. So how much vitamin D did you supplement to the patients?
Okay,
it differs, okay, yeah, but how many milligrams or units? Or
yes,
micrograms?
I can tell that it differs between 1,000 units to 4,000 units daily when it's taken, for example, every day for the patient. And on the other side, we have, for example, about 60,000 units when the patient got it intramuscularly, which might be also problematic in cirrhotic patients to apply the drug intramuscularly, but there are also studies doing it this way.